So welcome to the Cure panel, and with the spending per patient in the United States at twice that of the European Union, and the European Union having an average survival rate as good or better than the U.S., I would say that Europe does more with less. So today we want to discuss the European perspective on multiple myeloma with you, doctor, and learn more about the European myeloma model. Now, at ASH and ASCO, it appears that there's a cooperative relationship between researchers throughout the world with a large degree of commonality. Yet, there also seems to be differing views on treatment protocols. Would you outline what these differences in treatment are and why there are differences? For example, Dr. Hari mentioned U.S. and EU have similar patient populations, but EU performs 7 times as many allo transplants for myeloma. In addition, the U.S. uses the auto transplant, but in only 18.6% of patients. I would have thought myself that it was greater than that, and I was wondering if Europe does more than that, and if the transplant early or late is a backbone therapy, why isn't it significantly more than this, and maybe in the 60 to 80% range? Would you
comment on this? Yes.
Talk on these subjects, Doctor?
Yes. Well, I would say first that the collaboration between EU and the US is very important, and I think all the achievement has been made until now has been mainly due by an international effort, especially for this type of rare disease. An international collaboration is essential, and I think we learn from both sides of the Atlantic something one from the other. From a clinical perspective, I would say the first message is that myeloma is a rare disease. And especially for patients, the first message is you should ask how many myeloma patients a given doctor is seeing every single year, because this is making the major difference. Of course, a center where they can see more than 100 patients per year do have a completely different experience and approach from a center who might see only 5 patients per year. So the first important and general message for patients is go in centers where a given center or physician is seeing at least 100 patients per year. Otherwise, the risk is that you are seeing a wonderful physician, but once again, the professional attitude is coming from exercise. And exercise needs a number of events that cannot be so few, and unfortunately, to some extent, fortunately, myeloma is a rare disease, so it's not so easy to have a wide experience. This, I would say, is the first issue. The second issue is probably related to the fact that to some extent the world is going towards a more specialty approach. And before, we were mixing all the oncology, mixing together hematology and solid tumors. With time, we are trying to separate oncology from hematology, and even in a very specialist center, we are moving to even a disease specialist. A myeloma specialist, a lymphoma specialist, a leukemia specialist, and so on. So generally speaking, of course, going to a disease specialist might be better, but I don't think this is essential. what is essential is being a center where the experience is of at least 100 patients per year. Having said that, which is the last question was on transplantation. I would say that as allogeneic transplantation is concerned, this is not really a standard for multiple myeloma. Today, the indication for allogeneic transplant is, first of all, within clinical trials, so cannot be considered a standard of care. Second, it might be used in very young subjects, younger than 55 or 60, in early relapse, first, second relapse after diagnosis. Not the use of allogeneic transplant is not suggested today at diagnosis, of course, outside clinical trials. As autologous transplantation is concerned, this has been a huge discussion within the international community. Europe has been always more in favor of autologous transplantation. US, to some extent, has been more reluctant to the use of autologous transplantation upfront at diagnosis. Today, we already have 2 randomized studies clearly showing the benefit of autologous transplantation at relapse instead of keeping these procedures later on, autologous transplantation at diagnosis instead of keeping this approach for relapse. So today, I think there is a clear indication for the use of autologous transplantation at diagnosis. One of the major findings of these studies was that only 50% of patients who collect stem cells at diagnosis, they did really receive autologous transplantation at relapse for several reasons, comorbidities, different indications, but the first information is autologous transplantation at relapse can be delivered in the best possible condition only in 50% of patients, and therefore we certainly lose the opportunity of autologous transplant if we delayed this procedure after diagnosis. The last issue will be that these studies did show both improvement in remission duration and overall survival. So today, with the available information, the evidence is that autologous transplantation must be delivered at diagnosis.
So what is your percentage in the EU? Ours is 18.6.
No, we are 50%. We are 50% because, let's say, we had a study in the UK, actually. This is an incidence that is basically coming from UK, so we do not have really numbers coming from all over Europe. The issue is that in Europe, we might say that around 50% of patients do receive autologous transplantation at diagnosis. You might consider that around 15 to 20% of them they do not receive it for comorbidities, because of course you need to be in good clinical condition to receive a transplantation. Another around, if you want, generally speaking, 15-20% of patients do not receive it for a geographical condition, because of course to receive an autologous transplantation you need to be in the big centers. If you live in a small town far away from big cities, it's maybe not so easy to find a transplantation unit. And the last 15-20% is probably related to physician attitude, who might not suggest or consider this opportunity for those patients at diagnosis.
All right. We have the FDA in this country, and it seems to us that drug approval process goes at a snail's pace. In the EU, you have the European Medicines Agency, or the EMA. And is it more effective, do you think, than what we have here in the U.S.
No, it's much,
as far as drug
don't
approval?
worry, it's much worse. This is the minus here. You see, probably from a general point of view, the plus of Europe is that the treatment is more homogeneous. There is more public institutions. Everybody is receiving the same treatment. So there is more homogeneous treatment approach. The minus is that certainly is much more bureaucratic. So, for example, drugs such as carfilzomib that you do have in U.S. Is not yet available in Europe. And on top of that, probably also, some economical constraint in Europe is also reducing the opportunity to receive given drugs mainly for economical reason. Of course, the situation in Europe is different from US, because in Europe, generally speaking, the drugs are free for all citizens. So what for you is a private insurance, and therefore is based on the contract between the subject and the insurer. Here, the contract is between a nation and the reimbursement. So a given nation might decide to reimburse a drug, another might not consider the drug cost effective and will not reimburse the drug. So here is a more a state-based insurance approach.
So even though the EMA may approve it, it may not be approved by the nation.
Well, no, the process is, you should know, let's say EMA is equal to FDA. They both evaluate that the drug is effective and not toxic, period. Then every single nation has a given insurance from your side, might decide that they do reimburse that drug. They do not reimburse the drug. They limited the indication for that given drug. So then the nation, as for you, the private insurance, will decide when and how to reimburse a given treatment.
I see. When I view Europe, I see that you are one of the thought leaders, as a matter of fact, in myeloma. And as a matter of fact, I think of you, and I hope you take this as a compliment, as the Bart Barloghi of Europe.
Not really. Bart is... Bart has many, he did really a lot in U.S. He's changed completely the way to think.
Also, Pat Killingsworth just had a blog post, an article on his blog that said that arguably you are the best myeloma specialist in Europe. But in the U.S., I see a disparity between the best institutions, and you mentioned it, about the 100-patient requirement that you see as a necessity, that the best institutions have newly diagnosed life expectancies of 8 to 10 years or more versus the average of both the U.S. and EU, which is about 4 years. Do you see the same experience? in Europe that the best institutions provide life expectancies 2 to 3 times that of the local oncologist?
This is Jack. The only thing I would do is try to clarify with respect to transplant percentages. Are you talking about all transplant eligible patients, that it's either 18% or 50%, or is that of all myeloma patients?
Well, our 18.6.
They are only transplant eligible patients.
Thank you.
Okay, and what percentage of the total patients would that be, Dr. Palumbo?
The total patient will be 30%.
Yeah.
Okay, our transplant.
From a pure age point of view, will be 30%.
Yeah, so it's closer than you think.
Yeah, it is. Yeah, thanks, Jack. It definitely is close.
So on the total patient will be actually 15. So.
Okay, then it's very similar.